Good evening, everyone. I can see that we already have quorum, so welcome to today's webinar. Our webinar is scheduled to run from 6 to 7, 1 hour. And our webinar today is on protecting the kidneys, the pharmacist's role in preventing chronic kidney disease and acute kidney injury. So today we'll have two presenters, Dr. Joy Mungania, who is a pharmacist, a clinical pharmacist and public health specialist. She practices internal medicine at Meru Teaching and Referral Hospital. Dr. Joy is dedicated to improving patient outcomes through optimized medication use in both the inpatient and outpatient departments. Her professional passions include advancing evidence-based practice through clinical research, training and mentorship of healthcare professionals, and her future goals lie at the intersection of implementing research, program development, as well as policy that informs better clinical practice. We also have Dr. Brian Onduso. Dr. Brian Onduso is a pharmacist as well as a public health researcher. He's passionate and actively involved in pharmaceutical care when it comes to pharmacovigilance, research, regulatory, quality assurance and quality control, as well as medication therapy monitoring. He's also passionate about global health, One Health, and community service. Dr. Brian has got 5 years experience in service, and he works on projects and programs in public health, such as antimicrobial resistance, as well as universal health coverage and access. Dr. Brian believes in servant leadership, and his leadership extends to professional and student representation. Interesting to learn that he has also served as the Secretary General for the Pharmacy Students Association of Kenya. He's been the Treasurer of KEMU Students Council and various positions at the International Pharmacy Students Federation. Dr. Brian is currently working at Meru Teaching and Referral Hospital. So right now we are going to hand it over to Dr. Joyce to take us through the session. Thank
you. Thank you very much, Dr. Bettina. I hope I'm still audible. So thank you for that introduction and welcome everybody to today's webinar. On this World Kidney Day, we'll talk a little bit about protecting the kidneys and how, as pharmacists, we can contribute to helping prevent kidney disease from occurring, but also helping prevent kidney disease from progressing. So our learning objectives for this session will be to define and understand what we mean by acute kidney injury and chronic kidney disease, and then understand a little bit of the epidemiology of these conditions, discuss some prevention strategies concerning kidney injury and also concerning progression of kidney disease, and then wrap it up by discussing the pharmacist's role in management and prevention of kidney disease. And then we'll review a few sample cases just to demonstrate some of the concepts that we will have discussed. So I'll begin by defining some terms that we will be using. So the glomerular filtration rate basically means the flow or describes the flow of fluid that is filtered through the kidney, so through the glomerulus of the kidney. And the normal here is above 90 ml per minute. And then when we talk about creatine clearance, we'll be talking about the volume of blood that is cleared of creatinine per unit time, so as a rate. And usually this is a very effective method of estimating glomerular filtration rate. So they're not exactly interchangeable, but we use creatinine clearance to estimate glomerular filtration rate because we are not able to measure glomerular filtration rate. And then urinary albumin to creatinine ratio is a ratio that is calculated by dividing albumin concentration in urine by the creatinine, and this is a more accurate way of looking at if there is albumin excretion in urine. So there are various methods that we use to estimate creatine clearance, or to estimate GFR, and these calculations are such as the Cockcroft-Gault formula, I think that we have, that is very familiar, the modification of diet in renal disease, and the chronic kidney epidemiology collaboration calculation, so the CKD epi calculation. So the most popular ones are the Cockcroft-Gault and the CKD epi calculation for estimation of GFR. But I think the most recommended now is the CKD epi. So that is generally what we will tend to use majority of the times in clinical practice. So when we talk about kidney disease, what basically this refers to is either a functional with a structural or just a structural abnormality of the kidneys And KDIGO guidelines insist on, with implications for health, that these functional or structural abnormalities are causing some level of health dysfunction. And we classify kidney disease according to the cause. It can be according to severity of the abnormality and according to duration. So when we classify according to duration, that is when we get either acute kidney disease or chronic kidney disease, because this is based on how long the dysfunction has been happening. And then the grading according to severity and the causes are things that we will look at in a few slides down the road. So acute kidney disease then is these abnormalities either in structure or function or both that have lasted for a period of 3 months or less. An acute kidney injury is a subset of acute kidney disease. So acute kidney injury is a sudden, most of the time reversible, but not always, decline in kidney function. And this is measured by either an increase in creatinine or a decrease in urine volume. So AKI is a subset of acute kidney disease and is not the entirety of acute kidney disease. Whereas chronic kidney disease or CKD is these abnormalities that have persisted for a minimum of 3 months. So 3 months or more, again, with some implications to the health of the patient that is affected. And this can be defined by either a urinary albumin creatinine ratio of above 30 milligrams per gram of creatinine, or markers of kidney damage, one or more markers of kidney damage being present, which include like presence of things like nephrotic syndrome, nephritic syndrome, urinary tract abnormalities, and things like that, or a GFR of less than 60 ml per minute per body surface area. So if any of this is present for more than 3 months, then we say that that is chronic kidney disease. The diagnosis generally will tend to require at least 2 GFRs that are less than 60 or ACR that is above 30 milligrams per grams, at least 3 months apart, so that you can confirm for sure that this is chronic rather than acute. And especially in our setting where patients may come in with symptoms of some decline in renal function without necessarily knowing when the symptoms started and without us being able to establish what the baseline level or the baseline eGFR was at. So having at least 2 readings that are 3 months apart helps you know for sure that this is chronic kidney disease and is not an acute occurrence. So I hope this is visible. Sorry that the print is small, but basically this was just trying to show you the relationship between acute kidney injury, acute kidney disease, and chronic kidney disease. So there's there's a lot of interrelationship between these 3 concepts, in that acute kidney injury first is a subset of acute kidney, as we had said, but also contributes to chronic kidney disease, in that when acute kidney disease and acute kidney injury are persistent, then we end up in chronic kidney disease. And then patients who have chronic kidney disease are at a higher risk of getting acute kidney injuries or acute exacerbations or acute declines in their renal functions on top of the chronic kidney disease that they have. And this is a very common occurrence in patients with CKD, even at hospital. So a little more about acute kidney injury. In terms of epidemiology, mostly occurs in hospitalized patients during hospitalization, and is one of those things that are easy to miss in hospitalized patients, especially if we are not tracking the kidney functions regularly. It occurs in up to 67% of patients who are admitted in ICUs or critically ill patients. And it's an important contributor to prolonged hospital stays, more patient morbidity, increased healthcare costs, especially for hospitalized patients. In terms of incidence, first I have to start by saying that AKI tends to be very underreported. So this may not necessarily, though this may be the latest data, but it may not necessarily be a true accurate picture of the incidence of AKI because of how frequently underreported it is. But a, as the color red or pink gets deeper, the incidence is increasing. So you see we have a little more incidence in Asia, in America, North America, South America, and Asian countries. However, I will take this with a pinch of salt because there is a lot of underreporting of AKI or generally acute diseases, especially in Africa. So this may not be greatly represent the incidence in Africa. So in terms of causes, we can classify the causes of kidney injury into prerenal, intrinsic renal causes, and post-renal causes. So prerenal causes are those that occur before, that they are not related to the kidney. And a lot of them are usually volume dependent. Sudden and severe reduction in blood pressure or blood flow to the kidneys most of the times will lead to a prerenal acute kidney injury. So think of patients who've had severe blood loss, who are dehydrated, so they do not have enough volume, patients who have heart failure, or patients who have sepsis, so they're experiencing septic shock, or some form of occlusion like a thrombi, generally will get prerenal acute kidney injury. And then when you come to intrinsic renal, this is direct injury now to the kidneys. Could be from drugs, could be from toxins, and we'll talk a little bit about drugs. Could be from toxins, conditions like glomerulonephritis, acute tubular necrosis, missing. And then post-renal mostly are because of a sudden obstruction to urine flow. So we are not able to get urine output because there is an obstruction. So things that will cause obstruction like benign prostatic hyperplasia in men, or prostatic cancer, prostate cancer in men, or having kidney stones, something that is going to block the urine outflow out of the ureters. So in terms of risk factors for AKI, some are very, very similar to CKD we'll see. So older age, diabetes, hypertension, having chronic kidney disease, like we said, is already a risk factor for having an acute kidney injury. And then things like HIV infection, which is fairly common in our setup as well. Shock, nephrotoxins like NSAIDs, angiotensin receptor blockers, and angiotensin converting enzyme inhibitors, and contrast media that is used for radiology. So those are some of the risk factors. So in AKI, symptom recognition is very important. Like I have said, because it occurs mostly in inpatient settings, like in patients who are hospitalized, it is important to be on the lookout for some of those symptoms so that you're able to catch it and manage it early and intervene early. So confusion, chest pain or pressure, shortness of breath, irregular heartbeat, swelling around the ankles, and decreased urine output. As you can tell, some of these symptoms are very non-specific. A lot of patients might complain of confusion, chest pain, or things like that. But monitoring urine output might be a more objective way to be able to see declines in renal function. So in terms of severity, when we classify acute kidney injury in severity, there is this staging that is recommended by KDIGO. And there are also other different types of staging, but this generally, KDIGO takes a look at the rifle, the AKI, those others, and puts them together into this staging. So I focused on this because it's a bit more comprehensive and it's also updated regularly. According to KDIGO, acute kidney injury is 1.5 to 1.59 times an increase in serum creatinine from baseline. So you have the creatinine criteria and the urine output criteria. So you could look at how is the creatinine shifting or rising from your baseline levels, or you could look at how is your urine output decreasing, or what is the level of urine output in a certain duration of time. So for urine output, less than 0.5 ml per kg per hour for 6 to 12 hours is defined as acute kidney injury. And this is going to be stage 1. Then as the urine output declines more, or as the serum creatinine increases, then the grade gets worse. So decreases all the way to grade 3. And at grade 3, we either have no urine output or very little urine for prolonged periods of time, and very consequential or very substantial increases in serum creatinine. So why does kidney protection matter, or why is it important for us to protect our patients and ourselves from getting kidney injuries? So like I said, AKI frequently occurs in hospitalized patients. So these are patients that are already receiving care, are in an environment where they should be receiving care. So this tells you that this is preventable if we are just on the lookout for symptoms and for markers of acute kidney injury, then we can be able to prevent it. Many kidney injuries are medication related and they're preventable. And as pharmacists, this is one of the areas where we are able to actually intervene because we are the medication experts. So it is also consequential because acute kidney injury will lead to prolonged hospital stays. It will increase costs that are associated with managing the kidney disease. It can lead to poor prognosis, especially in critically ill patients. When a patient is critically ill and then they get an acute kidney injury, their prognosis worsens substantially. And us as pharmacists can play a key role in ensuring safe prescribing to reduce medication-related harm to the kidneys. So in terms of medications, there are some certain common medications or drug-related causes of AKI, like non-steroidal anti-inflammatory drugs, which is a very common cause of AKI that we are probably aware. Aminoglycosides, vancomycin, contrast media, ACIs and ARBs, especially in patients who are volume depleted. And then there's this combination of ACI or an ARB in a patient who's also using a diuretic and using an NSAID. So this, because of the diuretic, reduces renal perfusion to the kidney, which makes the kidney more susceptible to injury. And then you have ACIs and ARBs or ARBs and NSAIDs, which increase the risk of injuring the kidney. So this combination is something that we need to look out for, especially in patients who have heart failure, in patients who already have CKD, so that we are not contributing to injuring the kidney because of these three drugs that have an effect together that increases the risk of injuring the kidney. So how do we actually prevent acute kidney injury? Avoid unnecessary use of drugs like NSAIDs unless, and when used, should be used for the shortest duration of period possible to be able to treat what they are meant to treat. And then it is important to identify nephrotoxic drugs early and be able to manage each potential nephrotoxin individually. So for instance, if your patient has to be on a nephrotoxic drug like amphotericin B, there are lipid formulations that are a bit more safe to the kidney. You could prehydrate the patient and then monitor their renal function tests so that you see if there are any declines and catch them early and respond early. For aminoglycosides, you could use OD dosing as opposed to more frequent dosing like twice or thrice daily dosing. This is a bit safer for the kidney, and especially for patients who are already having declined function, therapeutic drug monitoring for aminoglycosides is really, really important. I know in the majority of our settings, TDM is not available, but it is important to know that it is indicated if you are seeing a patient with declining renal function and have to absolutely use an aminoglycoside. It is important to look at the level because the kidney injury risk is dependent on the drug level. And then, of course, monitor renal function tests. And you could also explore local use of aminoglycosides for some conditions. For instance, some gram-negative infections, respiratory infections use aerosolized aminoglycosides, and that helps prevent that systemic absorption of the aminoglycosides and protects the kidney. So for vancomycin, weight-based dosing can help not overestimate or overshoot the dose of vancomycin. And also therapeutic drug monitoring is indicated here, and especially for patients that have declining kidney function. And then if we're using contrast media in patients who have a risk for acute kidney injury, it is important to use the lowest dose that is possible. And you could try volume expansion strategies like with AIDS before using the contrast media, and also oral N-acetylcysteine can be used in high risk patients to prevent kidney injury, and it can also be used if kidney injury develops because of contrast media. In our practice, we know our patients, in some cases, will tend to use herbal medications. If we can play that role of advising our patients to either avoid herbal medicines or for safely using herbal medicines. It is safely using them is a bit controversial because it is a bit difficult to estimate what is the correct dose. So especially in patients who already have declining kidney, it is important to just tell them to avoid herbal medicine use so that we do not aggravate the problem. Where I work, I think we recently had a patient who came in with kidney failure, like complete kidney failure because of a herb, a very common herb, but they seem to have used a bit of an overdose. So this is something that we generally might see. So in terms of chronic kidney disease, the global prevalence is close to 10%. And we have around 800 million people living with CKD in the world right now. And that burden is increasing, and especially increasing because we are seeing the risk factors of CKD increasing. So if you look at the global burden here, and the burden gets worse as the red color intensifies. So you can see we have a lot of the red in Africa and a little bit in Asia, and a bit in Asia and some parts of South America. But as you can tell, in sub-Saharan Africa, we are not doing too well. And then the map here below is showing you the mortality. So again, mortality seems to be high in sub-Saharan Africa. And if you look at Kenya, we are at somewhere between 12 to 15% prevalence. But when it comes to mortality, we are among like the worst ranking countries. And we are somewhere in the range of 60 to 240 per 100,000 population. So not doing too well. CKD risk factors again overlap with AKI risk factors, like I said, and this list is not exhaustive, but I have highlighted the most common that we might see. So diabetes will account for almost half of the CKD patients and of CKD cases, and hypertension for like 20 to 30%. So you see, as the prevalence of diabetes and hypertension is rising, then we will continue to see more chronic kidney disease happening. Unless, of course, we institute measures very early on to prevent this. And then in terms of non-modifiable risk factors, we have family history of kidney disease or diabetes or hypertension, older age, and the Black population is generally more susceptible to CKD compared to Asians and Caucasians. In terms of severity of CKD, so there's a grading system that uses the level of albuminuria or albumin presence in urine, or the GFR category. So GFR categories. So in this case, we have 6 categories that are based on GFR. So from grade 1 to grade 5. With 3A and 3B, which makes it 6. And then we have from A1 to A3 based on albuminuria, and we are increasing from A1 to A3 and decreasing GFR from G1 to G5. What I will want to highlight here is just the contribution of albuminuria to prognosis of CKD. So for instance, if you look at a patient who has just mildly to moderately decreased GFR, but has severely increased albuminuria, their prognosis is much, much worse than the ones who just have moderate or mild albuminuria. So albuminuria is an important prognostic factor in CKD, and it is important to keep this in mind so that if there are things we can do to control the albuminuria or to reduce the albuminuria or reduce progression from A1 to A2 to A3, then it is important that we institute those measures early to prevent the patient from getting to prevent mortality related to CKD. So in terms of symptom recognition, again, a lot of them in CKD are very similar to AKI, but also very non-specific, fatigue. So see, 70% of patients will present with fatigue, which is very non-specific. So shortness of breath, leg swelling, muscle cramps. So it is important to just have in mind the risk factors so that you look out for these symptoms because they can be very non-specific. So then basically you would need to identify adults at risk of CKD. And then adults at risk for CKD should get testing for GFR or ACR or other markers of kidney function. And if the GFR is less than 60 or ACR is more than 30, as we had said, then you either classify them as having AKI or classify them as having CKD. And then stage as appropriate, establish the underlying cause of your chronic kidney disease and estimate the risk of progression and also initiate treatment as appropriate. So in terms of stages of progression and some estimation, some therapeutic strategies that we can use. So first, patients with normal GFR, screening for CKD risk factors like diabetes, hypertension should be ongoing all the time, especially in patients above 40. And then the ones that have an increased risk, either have one or more risk factors, then you should initiate strategies that decrease the risk of developing CKD and keep screening for CKD frequently. And then if you see kidney damage has already happened, then diagnosis and treatment, early diagnosis of the kidney damage, treatment of kidney damage, treating the comorbid condition or the underlying cause for the kidney damage, and instituting strategies for slowing progression is important. If you start to see decline in GFR, basically the kidney disease is already progressing. Think treating complications and starting to prepare the patient for like dialysis and transplants. Then patients who are already in kidney failure, then you have to put them on renal replacement therapy. And if all of this, all of this happens, then there is a high risk of complications happening and eventually progressing to death from CKD. So some of the management principles related to CKD is basically, as we have been saying, manage the underlying condition, ensure it is well controlled. Delay progression to end-stage renal disease, because once we get here, then we have to do renal replacement therapy, and we know, the cost, the quality of life implications that come with renal replacement therapy. And then manage the complications and have in mind the cardiovascular disease risk that is accompanied by chronic kidney disease. So for example, and I used diabetes and hypertension as an example because majority of the chronic kidney disease cases we will see in Kenya right now will be because of diabetes and hypertension. So if you're thinking non-pharmacological management, so lifestyle strategies like healthy diet, physical activity, adequate physical activity, having patients stop smoking and then manage their way that they're not obese is something that we should be looking at as healthcare providers. And then if you're looking at first-line drug therapy, you should want to very early on initiate drugs that can prevent that decline in kidney function. And we will talk a little bit in detail about some of this. So like SGLT2 inhibitors, you want this then will be first line for patients who have diabetes, hypertension, and are starting to have or have CKD. And then if they're hypertensive, you want to initiate RAS blockade early, and especially if they have albuminuria, because this is another class of drugs that is going to prevent progression of CKD. Then there will be other add-on therapies for diabetic patients like the GLP-1 receptor agonists that have become very popular now, but they also have a benefit in reducing progression to chronic kidney disease because they help with glycemic control and they help with weight management. And then you'll see non-steroidal mineralocorticoid receptor antagonists like finerenone also are newer drugs that are coming on board into the arsenal of drugs that decrease the risk of progression. Always think about cardiovascular risk when you're thinking about a patient with chronic kidney disease, with or without diabetes. But when they have diabetes, they have hypertension, and they have chronic kidney disease, their risk of cardiovascular disease is really, really high. And this might be the thing that actually kills them. So it is important to also take care of that. So the next thing to think about is managing CKD complications. CKD comes with very many different complications, anemia, and here you want to individualize therapy based on the patient. So if there are less than 10 erythropoiesis stimulating agents are helpful, and you want to maintain a HB of less than 11, between 10 to 11.5 grams per deciliter. Ensure you have adequate iron. So if your TSATs, your transferrin saturations are less than 30%, or your ferritin levels are less than 500, then you want to also start supplementing your iron early so that your erythropoiesis stimulating agents can work better. I won't go into a lot of detail into the specific CKD complications because there are many and they have a lot of detail into how to manage them. So I'll just touch on them. And then CKD, mineral and bone disorders, you want to use vitamin D3 because the kidney is not able to activate vitamin D3 anymore. And this is going to have implications for your calcium and phosphate metabolism. If you have hyperphosphatemia, you may want to put your patients on phosphate binders. So for these complications, you will need to manage patients as they come and try to anticipate the complications happening and think of strategies to prevent them. Patients, especially in advanced kidney disease, will develop metabolic acidosis or at a higher risk of developing metabolic acidosis. So you might want to correct this to maintain a serum bicarbonate level of above 22 milliequivalents. Hyperkalemia is also pretty common. So reducing dietary potassium intake, stopping drugs that also might contribute to hyperkalemia like NSAIDs, the COX-2 inhibitors, and potassium-sparing diuretics like spironolactone, beta blockers, ACEIs, and ARBs, and then avoiding just general salt substitutes and other supplements that contain potassium might help you keep potassium within normal levels. So then the next thing to think about, as we have been saying, is preventing progression. So the patient you have already has developed CKD, but maybe they are in grade 2 or grade 3, and they are not yet at end-stage kidney disease. We want to try and prevent or slow down that progression as much as we can. And so optimizing blood pressure control here is really important. Optimizing their glycemic control if they are diabetic. And this requires individualized glycemic control because they tend to be mostly patients with a lot of comorbidities. So you could individualize this based on the patients. Not all patients are going to get an A1C target of 7%. It is important to individualize to the different patient categories. And then you could use ACE inhibitors and ARBs in patients with proteinuria or albuminuria because this has been proven to reduce proteinuria and then reduce the risk of progression of CKD. And then SGLT2 inhibitors are renoprotective, non-steroidal mineralocorticoid receptor antagonists are like finerenone for DM patients is also renoprotective. And as always, it is important to keep monitoring the function of the kidney and electrolytes. So when it comes to SGLT2, I just put this here to just show you an aggregation of different studies and different SGLT2 inhibitors and what their benefit is to the decline of eGFR. So on your x-axis, I think, is your GFR. And then on this axis is your months since starting treatment. So these patients were followed up for 36 months. So the ones in blue are patients who were put on an SGLT2 inhibitor. And for this, it's either empagliflozin, DAPA, or canagliflozin. So at first, there was a decline in GFR. As you can see, very early on when treatment started, there was a decline in GFR. And this is kind of expected with SGLT2s because of a bit of natriuretic, diuretic effects. So they kind of cause volume depletion. So you see that decrease at the beginning. However, it starts going back up, and by the 12th month, so if a patient is on the SGLT2 inhibitor for 1 year, after 1 year, you start to see the GFR actually declining a lot slower than patients who are not on an SGLT2 inhibitor. And then for non-steroidal mineralocorticoid receptor antagonists, this is an aggregation of these two studies, Fidelio and Figaro, that looked at finerenone. And finerenone actually led to almost a 23% less incidence of kidney death because of kidney disease and decline to end-stage renal disease. So it is actually protective, but remember, this is for patients who have type 2 diabetes and have some level of albuminuria. So like I said, GLP-1 receptor antagonists can also be used because they are can be used because they are going to help with obesity management. They're going to help with glycemic control. So for patients with diabetes, they actually help reduce the progression of CKD. And they also have cardiovascular disease benefits. As with the other two classes we have mentioned, they also have cardiovascular disease benefits. So then a pharmacist comes in almost every stage of the cycle of managing a patient with CKD. Pharmacists provide patient education, whether it is preventive patient education for how patients can maintain healthy kidneys. We can collaborate with other healthcare providers to provide care, to manage cardiometabolic risk factors that we have been talking about and be able to provide that follow-up for patients, to ensure that patients are getting renoprotective therapies within, the drug therapy that they're on. We can help with risk prediction, identifying patients who are at a high risk, as we have described with the risk factors, and then being able to provide them education and provide them follow-up, counsel patients on lifestyle modifications, and generally do shared decision-making with the patients, with other healthcare providers on how to optimize patient care. So it is important that we recognize signs and symptoms early, especially in high-risk patients. Like we said, they are non-specific generally. A lot of times can be non-specific, so it is good to have a high index of suspicion. And in community pharmacy settings, if you do see a patient who comes to you for refill of their medications, their diabetes medications or their hypertension medications, and you start to see some of these symptoms recurring, it is important to just refer them early on to get additional checkup. Medication reviews is, again, our stronghold. It is important that we do thorough medication reviews. We assess for adherence. We see if all the medications patients on are actually indicated. Then patients tend to have very complex regimens. So it's important that we look at drug-drug interactions and try to simplify regimens as much as possible whenever possible. Reviewing over-the-counter medicine use. Our patient population, our general setting tends to see a lot of over-the-counter medicine use. So it is important to keep reviewing patients and what drugs they're using, especially the risky drugs like NSAIDs, them for how long are they using them, so that we limit how much we are exposing the kidneys to potentially nephrotoxic drugs. Then look at dietary supplements, look at herbal remedies that may be harmful to the kidney, and review this as well. It is important to calculate estimated GFR. Every time you see a patient or encounter a patient and you are able to access their creatinine levels, it is important to estimate their, so that you have an accurate way to dose medications for their renal function. So this is basically just summarizing all that I have said. So optimize the medication impact, let the medication be necessary. The medication that the patient is on, ensure it is necessary. And if there's any necessary medication the patient is not on, ensure that they are put on it. Then agree medication reconciliation together with other healthcare providers and minimize medication-related problems. So I did not go into a lot of detail with this, but I just put some medicines that may require dose reductions if you come across patients with CKD who are on these medications. And some are very commonly used. For instance, I find in my practice, like metoclopramide is something we do not necessarily think about a lot to renal dose. And this can cause very irreversible extrapyramidal side effects if we do not appropriately dose it for patients with chronic kidney disease. Think about some narcotics, digoxin, and decreased renal function contributing to digoxin toxicity. Some statins like rosuvastatin also need to be adjusted for the patient's GFR. Some antimicrobials, antifungals like fluconazole, aminoglycosides for sure, septrin, nitrofurantoin, you might need to adjust them for the patient's GFR. Anticoagulants like enoxaparin and also the direct oral anticoagulants like rivaroxaban, you will also need to renal dose them or adjust them to the patient's GFR level, and then things like allopurinol and methotrexate as well. Then the other thing is to manage complications. So all those complications that we talked about, then as the pharmacists ensure that they are all taken care of within the patient, the therapeutic plan of the patient, ensure that they are being taken care of and they're not slipping through the cracks. And especially what I have found in clinical practice, especially, we do tend to forget a lot about the mineral bone disorders that are associated with CKD. So ensure that is also not missed. And then address the cardiovascular risk factors, like we said. This is likely to be a high cause of mortality for patients with CKD. So if they need to be on statins early, let them be on statins early. SGLT2 inhibitors also reduce cardiovascular disease risk. So if they are eligible, then let them be on that. When patients come in with acute illnesses, a lot of times we'll have to discontinue some medications in the short term because they are acutely ill. For instance, they're acutely ill, we might need to discontinue the metformin for some time. We might need to discontinue the SGLT2 inhibitors for some time. There tend to be a lot of gaps when medications have been discontinued and now need to be reinitiated and they are not reinitiated. So this is another role that we can play really, really well, where we ensure with medication reconciliation helps us identify what medications were stopped and then develop a plan on when they should be reinitiated for the patient. And then we can help in preparing patients for renal replacement therapy. So patient education is something that we generally cannot avoid. We interact a lot with the patients in both outpatient and inpatient settings. So cancel patients on NSAID risks. If you come from where I come from, then we tend to use NSAIDs for everything. When seasons get cold and there are arthritis flare-ups, we use NSAIDs. When people have colds and flus, they use NSAIDs because of mistranslation of what a cold is, because of the vernacular translation. So there's a lot of NSAID use and over-the-counter NSAID use that we should warn patients about. We should also tell our patients that have diabetes and hypertension that they should get their kidney function testing regularly and follow up with their clinic appointments. And then we could cancel on dietary changes and do appropriate referrals to nutritionists as well for that support. So this World Kidney Day, there are 8 golden rules for healthy kidneys that we should talk about to our patients. So one is that they should keep fit and active, control their blood sugar levels, monitor their blood pressures, eat healthy and maintain healthy weight, maintain a healthy fluid intake, do not smoke. Smoking is now a risk factor for nearly everything. So cessation of smoking, for them to avoid over-the-counter pills on a regular basis, and to get their kidney function checked, especially if they have one or more risk factors. So this is just a summary of key points on medications in CKD. So I'll not belabor that because we have talked about it already. I'll stop here and hand over the session to Dr. Brian to take us over the cases. And as he does that, I'll try to respond to any questions that are in the chat. Over to you, Dr. Brian.
Thank you, Doc. So in the next session, it's still a continuation of the first session. I don't, Doc, you'll still project the slides.
Yes, I'll just let me know when to scroll.
All right. So after having learned about all that we as pharmacists can do, we're going to take like 2 or 3 case studies and try and interpret if we can make a few changes that will of course help our patients. So in our first case study, we have a 68-year-old man, of course weighing about 70 kilos. This patient was admitted about with a 4 days history of fever, a productive cough, and shortness of breath. The initial diagnosis was, of course, community-acquired pneumonia. His past medical history includes hypertension, type 2 diabetes mellitus, and osteoarthritis. His medications at home were metformin 1 gram BD, Espril 5 milligrams BD, ACTZ 25 milligrams OD, and diclofenac 50 milligrams, of course, TDS, that is whenever necessary. On admission, the patient was given a VSEF. His baseline laboratory investigation showed that he had a creatinine of 75 ml from a recent visit, which was, of course, on the third day rose to about 203 ml per minute. His urea is elevated at 12 millimoles per liter. The potassium levels were a bit high at 5.6, and the urine output over the past 12 hours, it was recorded to be about 300 milliliters for that whole period. So from this case, we will first want to identify if the case is a chronic kidney injury or an AKI case. I don't know, somebody can just raise their hands up and tell us from the information that we've just had if this is an AKI case or a CKD case from that information.
You could also type in the chat.
Yes. Maybe we could do this fast in the interest of time. We're left with about 10 minutes. Anybody who can tell us, maybe Doc, you can go back to the previous slide. Dr. Josta, maybe the previous slide. Yeah, thank you. Yes. Yes. Is this a case of acute kidney injury or a chronic kidney injury? I'm not seeing any information. Is there any information in the chat box, Dr. Bettina or Dr. Mutuma?
No, none that I can see.
All right. So this is of course a case of acute kidney injury. You can remember, thank you, Joseph. In the definition, Doc had said for chronic it has to be persistent for more than 3 months. In acute kidney injury, we said for it to meet that criteria, there has to be a reduced urine output and a reduced an increased serum creatinine depending on those 3 stages. So from this presentation, you find that is a case of AKI, and this might most likely be due to the infection, because this person presented with a case of pneumonia. The person was also on a number of medications. We saw earlier on that the triple whammy effect would most likely cause cases of AKI. The person is on enalapril, is also on diclofenac. Yes, which will of course all augment and lead to the triple whammy effect. The next question was the next slide, Doc. Yes, what therapy adjustments need to be made from our presentation on this case study? What are the various drug therapies that we can identify that we as pharmacists can maybe make to optimize this patient's treatment and to prevent, of course, progression to the next stage? I'll give a minute for this. Yeah, thank you, Doc. So we will definitely need to stop diclofenac. What else can we do? Of course, remove diclofenac. I see everybody is in line with that. Stop metformin, switch to linagliptin. Yes, metformin, because the patient is in AKI, and AKI has been known to lead to, of course, lactic acidosis. We can definitely reduce the dose of metformin. I don't see any other contribution. So those are the changes that we can make. We can adjust the dosage of metformin, as we've said. Lisinopril, because of the triple whammy effect, we can hold on it. Use CCB for blood pressure control, and then monitor the electrolytes, the blood pressure, and glycemia. I saw somebody type something, but it has just disappeared. Yes, we'll move on to the next doc. Next case file. In this, we have DW is a 43-year-old female. She has diabetes, hypertension, and CKD. She presented with bilateral lower limb swelling and vomiting for 3 days. She was noted to have poor compliance to medications at admission. Of course, not having taken the medications for the past 3 days. This is a second case due to similar symptoms. Her lab investigations showed that urea at admission was 20.2, which was a bit high. Creatinine was 805.3, which was way high. Potassium was 5.0, and sodium was 141. After a week of admissions, we repeated a USC, and then we found potassium to be again more elevated at 6.4. Sodium was 132, which is a low normal. Urea was 27, which was of course high. Creatinine was 945, which is of course almost, I think, like 10 or 20 times high. And then throughout the whole period of admissions, her BP have been always been high. She was on the following medications. She was on spironolactone, atorvastatin, DAPA, losartan, hydralazine, and Lasix, amlodipine, Lantus, and soluble insulin. She's on a number of medications, of course, due to the so many complications. So based on this information, we'll then respond to the next 2 questions, which is, of course, what needs to be done to optimize treatment and what could have been done to prevent the progression of CKD. Maybe you can move back to the previous slide, Doc. Yes. So in terms of treatment optimization, you realize that this patient has a number of medications. So what do you think are some of the interventions that can be made to treat this patient? You can type in the chat box, or if you feel free, you can also raise your hand and unmute and give us a response. Yeah, that will be done, Dr. Rabin. Thank you, Doc. So Doc is saying we can withhold spironolactone, consider use of a fixed dose combination. Okay. So yes, her potassiums have been a bit high, so we can consider holding the spironolactone. Any other response? Fixed dose combination. Okay, to reduce the pill of the burden. Okay, that's also a good intervention. Ensure medication adherence to control BP and glucose levels. Yes, that is actually very correct. Remember, one of the things that lead to these cases progressing is poor compliance to medications, which of course leads to spiking of BP and progression of the CKD. So if the patient was to optimally control the blood pressure, we'll definitely control this progression of CKD. So we need to counsel the patient on the importance of adhering to the medications to avoid the CKD. We can also shift the potassium as Doc had indicated. Then, of course, optimize BP treatment. We can continue with statins, CCB. The sugars will need to be monitored closely. The other thing we can do, because the creatinine was a bit high persistently, the patient can be checked on if there's the need to, of course, undergo dialysis to reduce the creatinine levels. Do you think we should stop or not stop the SGLT2 inhibitor for this patient? Dr. Mutuma, because you're the closest they can see, do you think it will be beneficial to stop or to continue the SGLT2 inhibitor?
I think, Doc, I could just discuss this a little in the interest of time. We
Yes.
put this question here because if you read the inserts for EMPA, DAPA, they will tell you below a GFR of that 25 for EMPA, 20 for DAPA, you should not use them. They are sort of contraindicated. So if you have a patient who has CKD, if you institute it early, we have seen that they can reduce the progression of the disease. But now, if the disease has already progressed and this patient is in end-stage renal disease, like our patient here, is an SGLT2 inhibitor useful or not useful? This could be sort of an off-label use because the manufacturer's instructions have still not changed. But there's a lot of evidence that is coming out now, especially in a that for patients that are using SGLT2s, that is showing that even in patients with end-stage renal disease, and advanced kidney disease, they are still beneficial for cardiovascular risk reduction. So as much as now the kidney has failed, we might not do much for the kidney. They do a lot for decreasing cardiovascular mortality, which is CKD patients have a very high risk of. So off-label SGLT2 inhibitors could still be used in end-stage renal disease, and this is the manufacturer's instructions could probably change in a few years because the evidence is coming out to support this. So that's something that in our practice we could take note of.
All right, thank you, Docs. I think that was the last case.
Okay, thank you very much, Dr. Brian. So as we come to a conclusion, I think key takeaways from this for me are kidney injuries are preventable, and as pharmacists, we play a central role in preventing them. Ensuring medication safety is one of the ways that we can prevent kidney injuries. It is important to always remember check renal functions, remind our patients with risk factors to have their renal functions taken, avoid the necessary nephrotoxins, and identify risk factors early. Help our patients adjust their medication to their level of kidney function so that we are not causing more harm. Help them with their dietary and other lifestyle management, and always, as necessary, partner with other healthcare providers to provide the best care possible for our patients and referrals as appropriate. That is it from us. Thank you very much for your attention, for putting your responses in the chat and engaging with us. Thank you. Back to you, Dr. Bettina.
Thank you, Dr. Joy and Dr. Brian. I can see we have 3 questions, so maybe you can pick it up. First question is from Dr. James. He says that this is informative, and how come when you're projecting the epidemiology, Uganda has a low prevalence? I think it was in the CKD. And then there's also another question on what hub was that was used, the case in Meru, and came with kidney failure, or what hub was associated with kidney failure? Are you able to identify the hub?
Okay, so thanks for the questions. So with Dr. with Uganda having less prevalence, like I said, with sub-Saharan Africa, generally the data is lacking or barely there. So you'll find that the ones whose data is barely there they might seem as if they are doing better, but that may not necessarily be the case. So it is very hard for us to say we have a higher or lower prevalence. We really cannot know. We don't know. And then the herb that was used for the patient, our patient was using a herb called the soursop. Soursop. So soursop has been used a lot of times in patients with malignancies because it is said to have anti-cancer properties. So here in Meru and in other places, it's boiled and patients take the drink, and apparently it helps with cancer. So this patient had had boiled a lot of leaves and came in renal failure, and unfortunately she did not survive it. Yeah.
Thank you, Doc. I think those are the main questions. Otherwise, to all who have appreciated Doc, I can see Lamek, Farida, Kamungi. Thanks for acknowledging the good work, and we are saying that we need more trainings like this, more trainings that are clinical oriented. So unless there's any other question, I think I'll request Silvanas to end this session as we do not have any more questions. Asanteni, there's another meeting, so we can all gear up to join it for the women empowerment. Thank you so much, everyone. The 422 participants, Asanteni. Thank you, Jashu. Thank you, Evans. Thank you, Nicholas. Thanks, Karen. Thanks, Anna. Asanteni. And have a lovely evening. And remember, together, let's combat AKI and CKD. Let's get screened.